moving on with the metastatic disease. So how do you, I know Frank mentioned that ARNOTE did not have overall survival benefit as of now, and I know the follow-up is ongoing. Does that factor into your decision making when you decide on one of the agents? As in, do you really think there is a big difference between these agents in terms of when you're talking about efficacy?
Yeah, it factors in a little. I just feel a little more confident recommending something that has a proven survival benefit.
Okay.
But there's the other side is it's well tolerated. It's certainly nice to have the option.
Yeah.
Yeah, I think it comes down to what we talked about earlier, and that at least I'm more comfortable with agents that have the longer track record, so the abiraterones, the enzolutamides, apalutamide. But a lot of times, what's driving darolutamide is drug-drug interaction. So if we need to use it, I think it's probably going to eventually show a survival benefit like the others do, and I'm perfectly comfortable using it. But definitely the ones with longer track record, I have more.
Also the tolerability, the lack of seizure activity, the lack of, any as much mental effect.
Yes. Yeah. We use it a lot at the VA. I think because our patient population is older, a lot of cardiac comorbidities, so that can take abiraterone off the table. And then they're all on direct oral anticoagulants for their cardiac comorbidities. So that takes enza off the table. And so we've been using darolutamide off-label even before ARNOTE. So we find we use it a lot, and I think because we use it a lot, I think our anecdotal experience is it's better tolerated because Bayer did have some evidence that it crosses the blood-brain barrier a lot less than, actually substantially less than enzalutamide. And Alicia Morgan's this group at Dana-Farber is doing trials looking at functional MRIs of patients getting darolutamide versus enza to really answer that kind of cognitive impairment, the depression, fatigue, all those toxicities. So that data is not out yet. But I just think anecdotally we find it to be better tolerated. But I think Frank's point is well taken. It's it is the newest kid on the block, so you do have to weigh that a little bit. But sometimes it's our only option.
But sometimes because it's the newest study or the most recent study, the control arm is getting a lot more quicker.
Yeah, that's fair.
One of the oral agents compared to the previous, like the Latitude study, for instance, barely anybody got abiraterone until they were castrate resistant. So that difference, I think, colors some of the overall survival data and all of that. Talk about your neurologic study.
Oh, yeah. So we didn't talk about my research interest, and gratefully funded by the Prostate Cancer Foundation, does look at the mental health impact of these androgen receptor pathway inhibitors, because this is a total aside. But we do know that ADT, that loss of testosterone, is associated with developing depression. All of the panelists know this, but I think one thought is from the direct loss of testosterone. For treatment refractory depression in men, sometimes testosterone replacement's actually used. There's a biochemical effect. But then also, as all the panelists have a lot of experience with, just the toxicity of ADT. So that kind of loss of masculinity, the weight gain, the muscle mass loss, the sexual dysfunction is huge, a huge quality of life impact. So that can drive the depression as well too. So, but what happens with ARPIs, we don't really know yet, and is one worse than the other? We kind of alluded to some anecdotal experience, but my work in the VA is using, just the huge VA database retrospectively to look at that. And then, like I mentioned, Alicia Morgan's this group is doing that prospectively in some trials. So,
so I think paying attention to patients' mental health as well as their long-term cognitive disorders and all of that is critical. It took us 40 years to realize that ADT therapy can cause, any kind of increased risk of dementia or mental cognition. And, now we're using these earlier in patients with longer survival. So we have to keep that in mind with the long-term effects.
How often are you discontinuing? It might depending on or giving a treatment holiday. It might depend on your treatment or setting or care setting, I'm sure. But is that a common occurrence or not a common occurrence?
I think I frequently start the discussion at about arbitrarily 2 years, but if they're continuing in remission and doing well, I start the discussion at least of trying to stagger off, maybe stop the ADT and then look into eventually stopping the oral agent, I don't know what.
I think we're waiting with bated breath for data because that ADREAM trial, cooperative group trial, where people got to stop their.
That's a single arm, though.
Yeah.
It was just a trial to see if we should build a phase 3, but I really
Right.
think we needed.
Yeah.
Yeah.
So if they had radiation to all sites of disease, I do extrapolate from Stampede. I will stop at 2 years everything and then monitor.
Yeah, they've done consolidation.
Yeah.
Local.
It's tough though, because all the trials were indefinite treatment, and that was where the survival benefit was, overall survival benefit was. So I'm not like pushing it, but I think we do zoom out, and I'm curious what everyone else thinks too. This is an incurable disease. I mean, people live a very long time, which is like incredible, and are living longer and longer. But their quality of life is, where our treatments help people live as well as they can for as long as they can.
Yeah.
And so I think if their life is, if they're miserable and they can't do the things they want to do, it is definitely something I strongly consider. And I wouldn't push them to stay on treatment. So.
Yeah, I think it's another situation where it's shared decision making, and we all have some patients who do not tolerate androgen deprivation or the oral agents very well, and if they understand the risks and the potential benefits of stopping and they want to do it, I think that is a very reasonable decision to make with them as a shared decision.
To me, it feels like, and Frank can comment, of course, but that Black patients have a much more of a chance of staying in remission with the combination than just ADT. Even on the DREAM trial, the 2 patients who relapsed promptly, both of them were Black. And even in the study that I did, with 40% of the patients being African American of ADT plus minus ENZA, the patients who were African American had an equal benefit or equal outcome clinically only if they took the combination. So ADT alone, even in the SWOG trial where we randomized patients after 8 to 9 months, about half of my Black patients would not even get to that PSA nadir and were not eligible to be randomized. So that says something for the different biology, and there you may want to continue the therapy longer. Frank, have you had any?
Yeah, I wasn't aware of that, that particular data you cited. But I do think that I work in Detroit. I have a lot of African American patients.
Yeah.
Some of which I inherited from you. But overall, they seem to have aggressive disease. But I've only practiced in the area where everybody, if they're willing, if I can talk them into it, get treatment intensification. So
Right.
Most of them do quite well. So anecdotally, I'm not aware that the difference might be there.
Right.
So I hardly ever, if I can help it, hardly ever see
Good point.
AT alone.
Right.
Yeah, we are in that era now, too.